This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today, we're looking at a fascinating new study from World Neurosurgery, set to be published in 2026. It's titled Decoy Lesion in Functional Multiple Pituitary Adenomas, Literature Review and Illustrative Cases on Diagnostic Pitfalls and Surgical Strategies.
This is a topic that I think doesn't get enough play in residency training, but it can absolutely haunt you in the operating room. We're talking about multiple pituitary adenomas, or MPAs. Usually, when we see a pituitary lesion, we're looking for a single culprit. But MPAs represent a special subtype that presents what the authors call dual challenges in both diagnosis and treatment.
Exactly. And the most provocative part of this paper is the concept of the decoy lesion. In the context of MPAs, you often have a coexistence of hormonally active and silent lesions. The decoy is a radiologically dominant tumor, the one that looks the most obvious on the MRI, that actually does not correspond to the hormonally responsible lesion.
That's a nightmare scenario for a surgeon. You see a 10mm macroadenoma on the right, but the patient has Cushing's disease or acromegaly caused by a 2mm microadenoma hidden in the left wing. If you just go for the big one, you're leaving the disease behind.
Right. The paper highlights this as a major diagnostic pitfall. When we rely too heavily on imaging dominance, it can adversely influence our surgical decision-making. The authors suggest that the presence of these silent lesions alongside functional ones can lead to a failure in achieving biochemical remission if the surgeon isn't prepared for the possibility of multiple tumors.
Let's dive deeper into the surgical strategies mentioned. If you are a resident or a junior attending listening to this, how does this paper suggest we approach this?
The study emphasizes that we can't just be lesion-focused in our planning. We have to be hormone-focused. Because these decoy lesions are radiologically dominant, they can be incredibly misleading. The strategy involves a high index of suspicion when the clinical and endocrine data don't perfectly align with the largest lesion seen on the scan.
It's about the discrepancy. If I have a patient with massive growth hormone elevation, but the MRI shows a tiny, subtle lesion on one side and a larger, non-enhancing area on the other, I have to ask, which one is the decoy? The paper suggests that in these functional MPA cases, we might need more aggressive exploration of the gland.
Exactly. The illustrative cases in the review show that if you only resect the visible, dominant mass, the decoy, the patient's hormonal levels won't drop postoperatively. You've treated the anatomy, but you haven't treated the pathology.
And that speaks to the dual challenge. First, you have to diagnose that it's an MPA, which is difficult enough given that one might be silent. Second, you have to decide if you resect both or if you can definitively identify the functional one.
The paper really pushes the idea that the hormonally responsible lesion is the priority. Even if a lesion is silent and radiologically dominant, it might just be an incidentaloma or a non-functional adenoma that happened to be there first. If the smaller, harder-to-find lesion is the one secreting ACTH or growth hormone, that's your real target.
It's a great reminder for our listeners. Don't let the decoy distract you. In neurosurgery, we often say, treat the patient, not the scan. But in pituitary surgery, it's more like treat the endocrine profile, not just the biggest hole in the bone.
Precisely. The authors conclude that recognizing the decoy lesion is key to avoiding surgical failure. It requires a nuanced understanding of the diagnostic pitfalls inherent in multiple pituitary adenomas.
Well, that's a vital lesson for the clinic and the OR. If you're dealing with a functional adenoma, always look past the most obvious finding to ensure you aren't being misled by a decoy.
It's a fascinating read. You can find the full review in World Neurosurgery 2026.
Thanks for joining us on the Neurosurgery Hub podcast. We'll see you in the next episode.
Goodbye, everyone.